Welcome to this presentation of new interRAI research published as part of the Frontiers in Psychiatry special issue on innovations in the mental health applications of interRAI assessments. My name is Keir Johnson from Doctors Manitoba, and I'll be the moderator for this session. Today's presentation will include two interRAI researchers who collaborated on a paper entitled An Examination of Correlates of Quality of Life in Children and Youth with Mental Health Issues. We'll begin with a brief presentation from the lead author, Angela Celebre. Angela is a PhD candidate in the School and Applied Psychology program in the Faculty of Education at Western University. The focus of her dissertation is examining quality of life in children and youth receiving mental health services. She has received funding from the Ontario Graduate Scholarship for this research. She will be joined by Dr. Shannon Stewart, Professor and Clinical Training Director at the Faculty of Education and an adjunct assistant professor with the Department of Psychiatry at Western University in London, Ontario. She's an associate scientist at the Children's Health Research Institute and associate scientist at the Lawson Health Research Institute. Dr. Stewart is an interRAI fellow and board member. She is the lead developer and international lead of the interRAI Children and Youth Suite of Instruments and has published extensively in the area of children's mental health. We will provide a web link to the articles in the special issue at the end of today's webinar. I'd like to turn things over now to Angela to begin her presentation.
Thank you for the introduction. I'm really excited to share our research work with you using the interRAI self-reported quality of life tool for children's mental health. I'm going to try to briefly walk us through the key points of the study to begin. So from the historical perspective, clinicians have been primarily concerned with symptomology and little attention was given to an individual's quality of life. However, there has been a shift within the healthcare system towards recognizing the importance of the client's preferences and life experiences. Notably, this has coincided with an increase in the development and use of quality of life measures, and studies have begun to demonstrate the vast utility of these tools. So research has begun to examine the relationship between quality of life and mental health. However, the majority of studies have been conducted in adult populations, with research in younger populations kind of trailing behind. And this is despite the finding that children with mental disorders have lower quality of life, even compared to those with physical disorders. In a recent review on how childhood mental and behavioral disorders affect quality of life, the authors identified a number of gaps in the current literature. So for one, there's a lack of quality of life domain profile research, particularly seeing as quality of life is a multidimensional construct. Most studies in this field also really only focus on disorders as opposed to mental state indicators. And finally, studies typically fail to analyze the association between symptom severity and impairment with level of quality of life. So the current study intended to close some of these gaps in the literature by investigating the association between symptom severity for a number of mental state indicators and domain-specific quality of life. And so this leads into the aims of the study, which were first to determine whether mental state indicators, so including depressive symptoms, anxiety, hyperactivity and distractibility, positive symptoms, and anhedonia, predict self-reported quality of life in children and adolescents receiving mental health services. And then secondly, to determine whether the predictive ability of these factors is stronger for a specific domain of quality of life. So two interRAI measures were used in the study. The first is the self-report quality of life child and youth mental health, which is a self-report survey that's intended to assess the subjective well-being and satisfaction of children and youth 7 to 18 years who are receiving mental health services. The pre-service questionnaire, which is the one that was used in the study, contains 33 items across 4 domains, which include basic needs, so things like living conditions, food, safety, and privacy, social, which includes things like friends and activities, respect from others, and family, individual, which includes items related to autonomy and health, and then finally services, which includes both school as well as treatment services. The second measure that was used is the interRAI Child and Youth Mental Health Assessment, or ChYMH, which is a comprehensive mental health needs assessment. So it's comprised of about 400 clinical elements that are used to assess psychiatric, social, environmental, and medical issues for school-age children between 4 and 18 years. Participants consisted of a convenient sample of 347 clinically referred children and youth who have accessed services from a tertiary mental health center in the province of Ontario. Of this sample, about 72% were male, 26% were inpatients, and ages ranged from 7 to 18 years old, with the mean age being just under 11. So children and youth were assessed using both the interRAI-ChYMH and the self-report quality of life assessment tools as part of standards of care. The plan for analysis was fairly straightforward. So first, frequency and descriptive analyses were conducted for all variables. Then Spearman's correlation and Mann-Whitney U tests were conducted as appropriate to assess bivariate relationships. And then finally, hierarchical multiple linear regressions were conducted to predict domain-specific quality of life from those 5 mental state indicators, controlling for age, sex, and patient status. So in terms of our results, we found that higher levels of depressive symptoms were associated with lower basic needs quality of life, with the final model explaining 2.9% of the variance. We also found that higher levels of anhedonia and depressive symptoms were associated with lower social quality of life, with the model explaining 5.6% of the variance. Furthermore, higher levels of depressive symptoms were associated with lower individual quality of life, with the final model here explaining 13.9% of the variance. And then lastly, none of the mental state indicators made a significant contribution in the analysis for services quality of life. And so none of them were included in the final model. So because of their significant clinical utility, interRAI quality of life measures are increasingly being used within healthcare, including mental health research. So on a broad level, interRAI quality of life data can help inform resource allocation within various health service sectors. On a more individual level, quality of life measures can be used to monitor a patient's progression over time and determine the impact of a specific intervention. interRAI quality of life measures can also be helpful in the diagnostic process by providing a window into the individual's perspective. And so this allows the clinician to gain insight into the areas of functioning that they're struggling with the most, which can then subsequently inform care planning. So to conclude, the key issue is that children with mental health problems have a significantly worse quality of life in comparison to typically developing children or those with chronic medical conditions. Unfortunately, there's a paucity of research identifying factors associated with quality of life in this vulnerable population. And so the significance of the current study is that it's the first, to our knowledge, to include such a breadth of clinical factors, so namely those 5 mental state indicators, in a comprehensive multivariate analysis examining determinants of quality of life. And really understanding the correlates of quality of life in children and youth receiving mental health services will allow clinicians to respond in more targeted ways. Thanks.
Thank you, Angela, for the presentation. The research is definitely very interesting, and we have a few questions we'd like to ask.
Absolutely.
Yeah, first, maybe a general question about why it's important to measure quality of life in young persons, and why was it critical to develop a quality of life tool specifically for young persons?
Yeah, those are great questions. So to kind of tackle the first one first, I think that there's really an increasing awareness around the value in obtaining self-reports of quality of life from children and youth in particular, and that's due in large part to this parent proxy problem. So extensive research has shown poor agreement between parent proxy and child report of quality of life. So we have, for example, a review by Upton and colleagues who found that parents of children from clinical samples had a tendency to report lower child quality of life compared to the children themselves. And this is because parents tend to perceive an illness to have more negative consequences than the actual child or youth. Research has also found that specific psychiatric disorders had variable impact on quality of life, depending on whether the rater was the child, the parent, or the clinician. Again, kind of highlighting that discordance between self and proxy reports. And these findings are really of clinical importance because by understanding which domains of quality of life are affected in a specific psychiatric disorder, let's say, as reported by the children themselves, clinicians can then focus on those particular domains during assessment, diagnosis, and treatment planning. In terms of kind of why it's critical to develop a quality of life tool specifically for young persons, I think this was critical, especially for those with mental health issues, because while there has been an increase in the development of quality of life instruments kind of more broadly, the majority of these instruments are intended for pediatric chronic care. And so because these tools were developed for a different target population, they don't really capture all the factors that we would want for our target population, which again are children and youth receiving mental health services. And so that's why in response to the need for more diverse quality of life tools, interRAI has really developed several self-report quality of life measures, including the one that's used in the study that's intended for younger persons.
Thanks, that's a great explanation. Maybe more of a practical question. So could you describe how the interRAI self-reported quality of life tool, specifically for children and youth with mental health issues, how that tool assesses the perception of well-being and life satisfaction among children and youth?
Yeah, absolutely. So like I mentioned, the quality of life tool is a self-report survey that assesses subjective well-being and satisfaction of children and youth receiving services from mental health agencies, hospitals, crisis units, schools, and other community services. And so the pre-service questionnaire, which again is the one that was used in the study, it contains 33 items that were developed based on protective factors and indicators of positive mental health that have been well established in the literature. And so then the structure of the quality of life instrument is composed of 4 major domains. So we have basic needs, which again includes living conditions, food, safety and privacy, social, which includes friends and activities, respect from others and family, the individual domain, which is broken down into autonomy and health, and then the services domain, which is broken down into school and treatment. And then children or youth are asked to rate how true each statement is for them based on a 3-point scale. So some examples of items included on the quality of life tool are, I can say what I need to say without feeling scared, which kind of falls within that individual domain. Or another item is, my family helps me with my problems, which falls more within that social domain.
Thanks. You mentioned earlier about how asking these questions directly from children and youth gives a better understanding of their quality of life. And I'm wondering if you could talk a little bit about what the clinical benefits of using a tool like this would be with children and youth with mental health needs.
Yeah. So I think in general, we know that quality of life measures give patients a voice in their own healthcare, which really does help facilitate that shared decision-making between the individual and their healthcare providers. And that really helps build that therapeutic relationship, which we know is so critical to positive patient outcomes. Specifically, the quality of life chime, it provides children and youth with a voice, again, kind of promoting engagement in their own healthcare. And the purpose of the self-report survey is really to help healthcare professionals identify those areas of strengths and need in order to maximize quality of life in their young clients. So like I mentioned in the presentation, really getting a window into the individual's perspective allows the clinician to gain insight into those areas of functioning that the child or youth is struggling with the most, which can then subsequently inform care planning.
Thanks. It's useful to have that clinical perspective. I know one of the things many people look to interRAI tools for is policymaking and quality monitoring and resource allocations and all those kinds of decisions. And I wonder if you could touch on, perhaps how the quality of life measures could be used to inform resource allocation within various health service sectors.
Yeah, so I think different service sectors may be more interested in certain quality of life domains over others since they provide different resources. So for example, the basic needs domain might be of greater interest to child welfare services, particularly the subdomain around safety. And we know that issues kind of around basic needs and safety sort of drive extensive resources, right? whereas within the educational setting, they may be more interested in the services domain, particularly the subdomain related to school. And that data could help inform resource allocation within sort of that school environment. So I think overall, quality of life data could inform resource allocation differently, kind of depending on the service sector.
Great. I'd like to bring in Dr. Shannon Stewart to the discussion and get her perspectives. I know she's a collaborator on this research and of course has a lot to contribute as one of the leads with interRAI in this area. So Shannon, how is quality of life different in children and youth compared with adults?
Great. That's a really good question because unlike adults who have a lot of control over their decision-making process and choices, children have really limited ability to make critical decisions about their lifestyle because they're so highly dependent on their parents and their caregivers. Despite that, there's really a common thread and common domains or constructs that remain consistent across the lifespan. And it's important that issues such as physical health, mental well-being, social connection, and sense of autonomy, regardless of your age, those are important constructs that impact life quality across the lifespan. Interestingly enough, emphasis on certain domains may change across development. For example, adolescents may be more impacted by the social domain, especially in the area of peer relationships, because that's very heightened at that developmental stage, whereas that's less likely to be the case in middle adulthood or young childhood. So factors related to the quality of life could also impact a child or youth differentially based on their change in development.
Thanks, Shannon. Could you describe the research that interRAI did to create this quality of life instrument?
Sure. It was a multi-year endeavor, and extensive work was conducted as part of the development efforts in relation to both the child quality of life as well as the family quality of life measures that are part of the suite within the child and youth instruments. In addition to the in-depth review of the literature and measures in areas of quality of life for children's mental health, focus groups, interviews with clinicians across a wide variety of disciplines such as nursing, psychology, psychiatry, occupational therapy, as well as social work, were completed to construct the items related to quality of life. And so these items were really developed based on ongoing feedback, content validity with clinicians, expert knowledge from the field across not only Ontario, but a variety of different countries. And we received feedback from a variety of those particular experts. And then once the instrument was completed, pilot testing was done and conducted with first children and youth, and then followed by a more in-depth implementation for a pilot project with mental health agencies. And then finally, once that data was collected, we conducted a variety of different factor analytics with domains exhibiting strong psychometric properties. We identified which items had the strongest predictive value, and then that's when we went on to publication and implementation across a wide variety of agencies.
So I have a few questions that I might get both of you to weigh in on if you see appropriate. First of all, I'm wondering about your confidence that we could use these measures in future research on quality of life in young persons in mental health and addictions in other cultures or countries.
So the instruments have been specifically designed to address four major areas with respect to quality of life in children. And while these key domains play a key role in the quality of life, regardless of culture, it's likely that there are differences in terms of across different countries and different cultures. And so given that quality of life for children is really in its infancy, we need to really look at future endeavors that will focus on pilot testing interRAI with these new instruments across multiple countries in the near future to actually obtain a better understanding of the cultural differences in the quality of life across the globe for children and youth. And really, interRAI is in a unique position given that it has over implementation in over 35 countries, and we would be able to facilitate that extensive study into the future.
What are some examples of interventions that can be used to improve quality of life for children and youth? And Shannon, maybe you'd like to start.
Sure. So the majority of research related to children's quality of life has been generated from research in kids with chronic health conditions, but little has focused on child and youth mental health in relation to quality of life. And so having the ability to obtain child-specific information with respect to tapping those domains will provide additional clinical information to develop new practice innovations that are client-centered, individualized in nature, that focus on specific domains that the child is struggling with, whether it be social relations, peer issues, with the intent to improve well-being and life quality.
Great. And what is the next step for research that should be done in this area? And welcome both of you to comment, and who would like to start?
Yeah, I can jump in here. So I think that there are a couple of interesting future directions. One would be to determine, whether the present study's findings are consistent when participants comprise of a community sample, because this would really help establish the generalizability of our results. And then kind of thinking just more generally, I think longitudinal studies could be conducted to explore whether there are critical periods during which certain mental state indicators are more predictive of lower quality of life. So as an example, depressive symptoms might be more predictive of quality of life in adolescence compared to childhood.
Shannon, do you have anything to add?
Yeah, and I think there's very little rigorous developmental work with respect to establishing family and child-based interventions to determine outcomes for kids. And substantial pilot work was really needed prior to the evaluation of clinical effectiveness of different approaches to determine the differential impact and cost effectiveness of different intervention approaches.
Well, thank you both very much for helping us understand your research and the potential applications. Thank you, Angela, and thank you, Dr. Stewart, for your work on this topic, and we look forward to future developments in this research area. Thank you for watching this presentation on interRAI's research in mental health and addictions. If you would like more information about this and related work, please contact us at info@interrai.org. That's info@interrai.org.
To see all the articles in the special issue of Frontiers in Psychiatry, please visit the website shown here, or click on the link posted below this video. Visit the interRAI website at any time to view new presentations on this special issue as they are posted.